This case history was based on a question from a medical residency exam.
Marco, I can't breathe.
Mama, hold on. We're here. You're not alone. Just stay with me. Help! Help! Someone, please. My mother can't breathe. She's inside the car. Please hurry.
We're coming. Stay calm, sir.
Bring the stretcher now. Wait, please. Be careful with her.
Sir, we need space. Let us work to help your mother.
Senor Rossi, I promise we will take good care of her. Stay close, but give us room.
Mama, stay with me. Please, hurry.
Resuscitate now. Get oxygen on her immediately.
Oxygen mask secured, sir. High flow.
On my count. Transfer to bed. 1, 2, 3, now.
Mama, stay with me. Don't leave me.
Sir, please step back. We need to move her safely.
Nurse, please get an IV line in. We need vitals and blood work immediately.
No, I can't leave her. She needs me.
Senor Rossi, please. We need space to work. Your mother is in good hands. Please wait in the reception lounge. We will update you as soon as possible.
Crackles present. Severely reduced air entry. Likely respiratory failure.
IV fluids running. Vitals on screen now. Oxygen 78%. Heart rate 110.
Push the bronchodilator. We need to open her airways.
Doctor, bronchodilator administered.
Chronic cough, weight loss? Could it be acute exacerbation of tuberculosis?
Tuberculosis, Riki? Her chronic cough and weight loss could suggest it, yes. But look at her now. This acute, sudden dyspnea doesn't fit a typical TB exacerbation. Where's the fever? The night sweats? Focus on the acute presentation, not just chronic symptoms.
But the textbook mentioned...
Patient's heart rate stabilizing slightly after the bronchodilator, Dr. Bianchi.
Come on, Paulo, pick up. I need someone. Pronto? Zia? It's Marco. Mama is in the emergency room. She can't breathe. I tried calling Paolo, but he's not answering.
Sat's dropping fast. She's at 66% despite high flow oxygen.
Prepare for intubation. We're losing her airway. Laryngoscope and tube, now.
Could this be asthma? The wheezing, the rapid fall?
Asthma, Ricci? No. While she has severe dyspnea and some wheezing, her age, chronic smoking history, and a lack of prior asthma attacks rule it out as the primary cause of this acute collapse. This isn't a typical asthmatic crisis. Focus on the entire clinical picture.
But the acute respiratory distress?
Laryngoscope ready, Dr. Bianchi. Tube size 7.5.
Good. Let's go.
Breath sounds markedly reduced, diffuse wheezes, expiratory phase severely prolonged.
Reduced, wheezes, prolonged expiration.
Note the severity, Ricci. This isn't a simple cough. Tube going in. Good. Inflate cuff.
Cuff inflated. Breath sounds equal bilaterally.
Elderly patient, chronic smoker, weight loss. This acute respiratory failure. I fear we might be looking at an advanced lung carcinoma.
Carcinoma?
Weight loss, chronic cough, heavy smoking history. Carcinoma is a likely underlying cause here.
Agreed. It's possible, but not our priority right now. This is an acute crisis. We stabilize first. Diagnosis can wait.
Oxygen saturation improving, now at 82% and rising. Vitals still unstable.
Carcinoma, yes. But crisis first. Stabilize, then investigate.
Mama, please, don't leave me. Not like this.
Given the chronic dyspnea and the patient's age and the crackles, could it be idiopathic pulmonary fibrosis? The textbook describes a Velcro crackle sound.
Richie, while IPF can cause chronic dyspnea and crackles, it's a slowly progressive disease. It doesn't typically present with such an acute, sudden collapse like this. And we haven't heard any Velcro crackles in this acute setting.
Indeed. And the response to bronchodilators, however minimal, would be atypical for IPF. We need to consider what caused this acute exacerbation.
SATs inching up. Hold current settings. Prepare for CT once she's stable enough to move.
Checklist started. IV secure. Sedation on protocol. Oxygen alarms set.
Acute failure on chronic disease. We're missing the trigger.
Zia, it's Marco. Mama is in the emergenza. Please call me when you get this. Paolo, where are you? I can't do this alone.
Dr. Bianchi, her SATs just plummeted to 50%, and her blood pressure is dropping.
Increase PEEP, check for pneumothorax. Get the defibrillator ready, just in case.
This is a rapid decompensation. What are we missing?
She's crashing.
Doctor, what if this is a severe asthma attack? She's wheezing, tachypneic, and crashing fast. It fits.
No, Richie, severe asthma is rare at her age. It usually begins much earlier in life. And she's a heavy smoker with a chronic cough, not the history of a lifelong asthmatic. Plus, the mechanical ventilation shows poor compliance, not air trapping.
BP still dropping, 72/44. Preparing norepinephrine infusion.
Asthma doesn't explain the cachexia, the chronic decline. There's another story behind this.
BP critically low, 60/40. Pulse is thready.
Keep compressions going. Push another bolus. Prepare adrenaline, IV stat.
If we don't identify the underlying cause immediately, we're only buying minutes.
She's dying.
Stand back. From this moment on, I lead this resuscitation.
Dottoressa Lombardi.
She's here. Finally.
The maestra herself.
It's her.
Status report, quickly. What's the current rhythm? And oxygen saturation?
Ventricular tachycardia, Dottoressa. Saturation 78% on 100% oxygen.
Conti, prepare for immediate cardioversion and get me a full set of labs now.
On it, Dottoressa.
Dr. Ferrara, review the patient's history. Any recent cardiac events or known arrhythmias?
Checking immediately, Dottoressa.
Couldn't this just be severe asthma, poorly controlled,
now in crisis?
Asthma? Wrong. Look at her age, 58. Onset in youth? Absent. Wheezing episodes documented? No.
And the chronic smoking history, it contradicts an isolated asthma picture.
Moreover, notice the airflow limitation is fixed, not reversible. This is not asthma. Stop clinging to textbook cliches. Now, focus. Flattened diaphragms, hyperinflated lungs, a pattern unmistakable if you know how to look.
Not fibrosis, not infection, but air trapping, chronic obstruction.
Correct, Bianchi. This woman has the profile of a lifelong smoker. Not asthma, not TB. This is chronic obstructive pulmonary disease. Administer bronchodilators immediately. Nebulized salbutamol, then ipratropium. Prepare systemic corticosteroids IV.
Yes, Dottoressa. Salbutamol nebulizer starting now.
And monitor her gases closely. Oxygen too high can worsen CO2 retention. Keep saturations between 88 and 92%. Too much oxygen can kill a COPD patient. You treat numbers, but you must never forget physiology.
So it isn't about pushing saturation to 100%. It's about balance, protecting her from CO2 narcosis.
This changes everything I thought I knew.
Maybe we should intubate deeper and hyperventilate her? That way we clear the CO2 faster.
No, Ricci. That would worsen dynamic hyperinflation and risk pneumothorax. In COPD, haste kills. Gentle ventilation, controlled volumes. Remember that.
Hyperinflation, pneumothorax, I won't forget.
Harsh tracheal sound, diminished breath sounds, prolonged expiration. A classic obstructive pattern.
Nebulizer ready, Dottoressa.
Please, start immediately. We must relieve this air trapping before anything else.
Past medical history, 35-pack-year smoking. 2 prior hospitalizations for similar episodes in the last year. Chronic productive cough for over a decade.
Exactly what I needed. These are the patterns of chronic obstruction, not an isolated episode.
Agrees with your assessment, Dottoressa. This isn't sudden, it's progressive.
A long smoking history and cough. Could it be chronic bronchitis instead?
No, Richie. Where are the purulent secretions? Where are the recurrent infections? Think before you speak.
Not bronchitis. No secretions. Understood, Dottoressa.
Look carefully. The flattened diaphragms, the hyperinflated lungs, the smoking history. This is an acute exacerbation of chronic obstructive pulmonary disease.
COPD, it all fits.
Concise, precise, unquestionable.
Conti, maintain oxygen saturation between 88 and 92%. Bianchi, ensure that corticosteroids are administered slowly.
A flow adjusted, Dottoressa. Saturation holding at 90%.
Corticosteroids infusing, Dottoressa.
Good. Now we wait for the bronchodilators to take full effect.
Pulse strengthening, saturation holding steady at 91%. Dottoressa, I think she's turning the corner.
Good. Her gases are stabilizing. Airflow is improving.
Incredible. She was collapsing minutes ago.
Crises demand discipline, Bianchi. Not panic. Precision.
Tuberculosis, fibrosis, asthma. I was so focused on the textbook, I missed the patient. Dottoressa Lombardi. She saw the whole picture, the history,
the x-ray, the physiology, it all connected. I won't make those mistakes again. I must learn to see.
Signor Rossi, your mother is stable. We've identified the problem and started treatment.
Stable? Really? Oh, Dottoressa, thank you. Thank you.
She's still critical, but the immediate danger has passed. We'll move her to intensive care for continued monitoring.
Dottoressa, you saved her. You truly saved my mother. I don't know how to thank you.
We did our best, Signor Rossi. Your mother is a fighter. She's in good hands now.
Keep hope. We will do everything we can for her recovery.
You gave us quite a scare, Mama, but you're strong.
Thanks to the doctors and you, my dear.
Dottoressa, seeing her like this, it makes all the lessons clear.
Every patient is a lesson, Ricci. Never forget that, and never stop learning.
In the relentless world of emergency medicine, every case is a lesson. What new challenge awaits our team tomorrow?